I have the honor to be among these elegant professors in the 9th session, the Breakthrough Clinical Trials. And we have the opportunity, we're lucky to have elegant speakers. The first one is Dr. Shehab El Etriby, Ain Shams University, and he will talk about the sprint trial extended.
Sabah al-Khair, dear professors and colleagues, it's a pleasure to be here. I'll now present the sprint trial and the extended results and the extended analysis of the sprint trial. The observational studies identified that there's a strong association between the blood pressure and the risk of cardiovascular disease, but with no evidence of the threshold for this relationship. And hypertension is very common, and the clinical trials demonstrate that the antihypertensive drug therapy reduces the risk of cardiovascular disease. However, the optimal target is still uncertain. So the research question of the sprint trial was to examine the effect of the more intensive high blood pressure treatment that's currently recommended to decrease the goal systolic blood pressure below 120 versus the standard treatment below 140, and the major inclusion criteria included patients more than or equal 50 years old with systolic blood pressure 130 to 180 with additional cardiovascular risk, but excluding stroke and excluding diabetic patients. It was conducted in 102 centers in the USA, and the patients were screened and randomized 4,600 patients in the intensive treatment and 4,600 in the standard treatment with the same demographic and baseline characteristics regarding the age, sex, and the ethnicity, and usually the same baseline lab characteristics. The primary outcome was the composite endpoints of MI, stroke, acute coronary syndrome, and acute decompensated heart failure, cardiovascular death, and the additional outcome was the all-cause mortality and the renal affection. Follow-up was for the cardiovascular outcomes, the fatal events, and safety events, and the blood pressure was monitored monthly for 3 months and then every 3 months. Most of the antihypertensive agents were used, 3 groups, and the diuretic, and the mean systolic blood pressure during follow-up of the intensive treatment was 121, and in the standard treatment was 136. There was a decision after 3 years to stop this blood pressure intervention as it showed a major benefit with the reduction of the composite endpoints and death from any cause. The number needed to treat to prevent the primary outcome was 61, and to prevent death was 90. Serious adverse events were, of course, more in the intensive treatment group, but with the overall benefit of the intensive treatment exceeded the potential harm. There were new insights on this trial investigating the risk of the intensive blood pressure lowering and prevention of heart failure, whether if this intensive blood pressure lowering will decrease the risk of heart failure. And they categorized the sprint patients by the 10-year predicted risk score for heart failure into low, intermediate, and high risk. And it was found that the reduction in the risk of heart failure among all these tertiles, but was significant only in the highest heart failure risk category. So we can prevent the risk of heart failure in the patients with predicted high risk of heart failure. And another analysis included, a post hoc analysis included exclusion of the heart failure from the cause of whether cardiovascular death or all-cause death, to see whether the intensive blood pressure lowering decreased the cardiovascular mortality and all-cause mortality due to decreasing the heart failure or not. So they excluded the heart failure and also the composite endpoints, cardiovascular death and all-cause death decreased despite excluding the heart failure. They again published a paper on the impact of the class of the antihypertensive drug used, whether a thiazide-type diuretic chlorthalidone was used in 89% of patients, lisinopril in 55%, and amlodipine in 90%. The thiazide-type diuretics and the RAS blocker demonstrated a protective effect and decreased the primary outcomes. The thiazide-type diuretics were associated with a reduction in the heart failure events, and the RAS blockers were associated with reduction of myocardial infarction, and both were associated with less cardiovascular death. So the greater exposure to these thiazide-type diuretics and the RAS blockers also contributed to reducing these adverse cardiovascular events. Again, in the patients who are frail, they are more liable to cognitive impairment and possible dementia. So the intensive blood pressure lowering in these patients contributed more to the dementia and cognitive impairment. They conducted a secondary analysis on whether it increased the lifespan or not, and it proved that in the middle age or more older, just older than the middle age, it increased the lifespan from 6 months to 3 years compared to the standard treatment. And lastly, there was a paper published in October 2022 about the secondary analysis and the follow-up of these SPRINT patients from October 2021 to February 2022. They conducted a research on analysis on these patients, and they found out that the patients who were on the intensive treatment group didn't have a consistent long-term decrease in the blood pressure. So at the end, there was no difference after 8.8 years in the cardiovascular mortality and in the all-cause mortality between the intensive treatment group and the standard treatment group. And this is due to the outpatient increase in the systolic blood pressure in the intensive treatment group. So this is important, is to have a consistent long-term management of hypertension. So my take-home message is that the intensive blood pressure lowering in certain subsets may decrease the cardiovascular events and prolong the lifespan. Frail hypertensive individuals should be treated with special care, as they already have an increased risk of cognitive impairment and dementia. Consistent long-term management of hypertension is the most important goal to avoid serious cardiovascular events and decrease mortality. Target blood pressure level is still a dilemma till now. Thank you.
Shukran, Shehab. It was nice to go through the SPRINT and post-hoc analysis. It is open for all the audience if anybody would like to comment or inquiry. I find that there is no hands up. However, I'll take the chance to have the query. Shehab, as we know that SPRINT raised many issues about its methodology, whether in the tools used in blood pressure measurement or in the population have been selected age-wise or cardiovascular risk-wise. Having a post-hoc analysis will not make these issues rising again, and
Yes.
will be more doubts about their results. This is number one.
Yeah.
And number two, it is very interesting to know that after 8 years, somebody else have looked at those patients and found really that intensive, those which were apparently having a good results appear to be after a couple of years are not. May you comment on that?
Yes, in answer to the first question, of course, there is a difference in the ethnicity, and this will differ between each continent, but especially in China, they did a study, and the intensive lowering, even in the more than 75 years old patients, decreased the cardiovascular events. I don't remember its name. Regarding the second question, again, please.
Yeah, the other question is those who are having studied the sprint population.
Maybe because of the regular follow-up, they avoided the regular follow-up visits and they were not having any symptoms. So maybe they didn't measure their blood pressure and they stayed on the same medication or even decreased the medication. So that's why their systolic blood pressure increased.
Shehab, thank you so much. May I ask what was the parameters they've used in the follow-up or the after 8 years to determine whether these two strategies are equal or not? Was it only the symptoms, the readings of blood pressure, the presence of mediated organ damage? What was the parameters they are looking for?
The health records in the clinics. They examined the health records throughout these 8 years in the clinics.
Okay, thank you so much.
Thank you.